Good afternoon or good evening, everyone. I'd like to invite you and say thank you for attending our third webinar in the Unmet series. This evening, we're looking specifically at the underdiagnosis of elevated Lp(a) and how patients and healthcare professionals can work together for change. So before we begin, just a couple of housekeeping rules. By all means, it would be lovely if you share where you're coming from, which country you're in, and if you're with an organization or a patient, it'd be lovely to share that as well if you feel like it. And this is being recorded, and it will be available within the next few days on our YouTube channel. If you'd like to put your hellos and welcomes in our chat box, and then if you have any questions for the panel to answer later on, please put them in the Q&A. Also, I'd really appreciate it because we have our wonderful patient ambassadors on the call. If you can add any questions directed to them, please do not make them too specific or ask about specific medication. Thank you very much. And now we'll get on. I'd like to introduce you to our wonderful panel. We have Emma Guerres, originally from Spain, but living in Switzerland. And we have Aidan Carl, who is a medical student in Amsterdam. And we also have Mark Rijken, who's also from the Netherlands, another one of our wonderful patient ambassadors. And we have Assistant Professor Fotios Barkas from Greece. So without further ado, oh, and of course, I probably ought to introduce myself. My name's Emma. I'm the Community Engagement Manager for FH Europe Foundation. So without further ado, I'll invite our panelists to introduce themselves in more detail and also explain a little bit about their story and then their expertise. With this webinar, we're taking a slightly different approach and we're having more of an open discussion. So it comes across hopefully as being more friendly and relaxed, but you'll still get plenty of key takeaways by the end of this. So I'm first going to pass on to Emma to share her story about elevated Lp(a) and her perspective on unmet needs as well. Over to you, Emma. Thank you.
Thank you so much, Emma. And I noticed Emma, so it's very similar. So as you said, I'm originally from Spain, living now in Switzerland. I learned about Lp(a) just by chance. My mom had a car accident, and when she was in the hospital and they were doing all the different testing, they told her, well, you should not leave now because you really have a severe blockage of your carotid arteries. And I remember she was telling me at the time they proposed her to do either what it's called, I believe I'm going to say the right name, endarterectomy at that moment, or to use stents. So at the end, my mom had the number of stents on her carotid arteries. And I was told at the time, you should pay attention because this may be genetic. My mom was also relatively young. So I started, doing the testing, and I came out that I had exactly the same problem. So it was clear that I had a problem, but no one told me this is linked to Lp(a). This is where the story begins. They were telling me I had a bit of high cholesterol, so they were telling me you should eat better, But there was something that didn't stick on that conversation. So I did a little bit of my own research, and I actually Googled, and I said, I have cholesterol, and they tell me I should eat better, but I had the sense I was already eating well. And I came across with the Spanish Association of Hypercholesterolemia, and I got in touch with them, and it's there where I was immediately told very fast, your problem is probably related to Lp(a). And since then, I've been 15 years on statins. I did have a problem in 2012, already on medication. I had a transient ischemic attack with no further consequences. It was very mild. But of course, my medication was increased. And I guess that for me, that showed the seriousness of the problem, that we have to be very much aware and pay attention. For me, when I had the diagnosis, I did discuss with my general doctor, general practitioner in Switzerland, which was fantastic. I have a fantastic doctor, and she took it very seriously. And I think she also probably learned more about it. So, voila, that's my story. Thank you, Emma.
Thank you, Emma, and thank you for sharing. And it's awful that your mum was in a car accident, but I'm very glad in that way that you were able to find out that it was, had the potential of being genetic, and then you were able to work with that and understand about elevated Lp(a) alongside your doctor as well. And now we're going to pass over to Aidan. Aidan's story is very different from Emma's, as Aidan was diagnosed, I believe, at the age of 6.
Yeah,
but
that's
again,
correct.
And again, that's due to your parents finding out, or your mum, sorry, but she had elevated.
Yeah. It has there's a lot of stories attached to it. I won't bore everyone with a lot of details because it's quite a long one. But to keep it a bit short, my name's Aidan, Aidan Kaal. I'm from the Netherlands and I'm studying medicine in Amsterdam. I am lucky enough to be diagnosed with LPA, or Lp(a) for that matter. My father is diagnosed with FH and my mother is diagnosed with LPA as well. And the reason why this is important is because if it wasn't for them figuring out that they were diagnosed with these diseases, me and my sister would never have been tested in the first place. There's a long history in my family line of, especially from my mother's side, where we've had a lot of bad situations with doctors who either weren't informed properly and didn't know of the diseases, their existence, let alone took us seriously. And when my father was diagnosed with FH and took his medicine every day, the FH values never changed. And the doctors just took for granted the fact that he never took his medicine, even though he did every day. My mother has Lp(a) and to this day still doesn't receive medication because the doctors here, they don't know what to do. And they're not informed. Even my own professors at my university haven't been informed on the matter. And that's probably also the reason why I'm here. I was diagnosed at the age of 6. And while I was diagnosed at the age of 6, I thankfully did have a very helpful doctor that, from me being small, already managed to explain in simple terms what the disease entailed and how it would work and influence my life. And because of that, I've been able to live with it properly and have fun. But my mother and my father never got that chance. So, yeah. Well, that's my story.
Thank you, Aidan. And yes, I mean, it's fantastic to have it from your perspective as somebody that got diagnosed so young, and that you're living with elevated Lp(a), as opposed to it having a huge impact on your life at the moment. But for both of your parents with the elevated Lp(a) and EFH, that's, as you said, that's a very different story. And for your mum not necessarily feeling or finding any support, that's pretty tough going. And we'll loop back round to that and the unmet needs very shortly. I'd now like to pass over to Mark, who is also in the Netherlands. And Mark has had, again, a very different story. So we've all got different stories, but they're all linked together as well. Over to you, Mark. Thank you.
Thank you, Emma. Yes, hello, everybody. My name is Mark, 49 years old, from the Netherlands, as been said. I'm a husband and a father. I'm also an FH ambassador and a patient representative at the Lp(a) Global Task Force, and have elevated LPA levels myself. Unfortunately, I was not diagnosed with the elevated Lp(a) such as Aidan did. So I had to experience the hard way or by means of a heart attack, or actually In the meanwhile, I had 2 heart attacks. I had 1 open heart surgery, 7 bypasses, and 1 stent. And or actually, after all of these events and operations occurred, it took still over 3 years, so 6 years after my first incident, that I discovered, or that I found a doctor who helped me discover that I had elevated Lp(a). And before that time, the doctors basically described my situation as a result of bad luck. I was one of a few who really had the bad luck, because I didn't have high cholesterol, I didn't have any overweight, I never smoked a cigarette in my life. So yeah, well, it had to be bad luck. Oh, and also there were no details known within my family, so therefore they didn't thought of genetics, or they could not also look for those. So it was bad luck. Having children myself, I of course did not want to also have them to have the bad luck issue. So we had them tested immediately when we found out that I had elevated Lp(a). And 2 of my 3 daughters also have elevated Lp(a) levels. And that's what partly explains my motivations to play an active role towards a more improved awareness of Lp(a). And that also is an unmet need to have more knowledge, more awareness, more information around this topic. So that is a little bit of my situation. During the rehearsal, I was challenged with a fun fact. So I think I will simply go ahead and repeat that also. So fun fact is that I live my life more or less the same as before all of this happened with my heart. So I work 100%. I drive a motorcycle on a daily basis. I play sports on a competitive level and more increased to before. Really try to live a healthy and active life. And to my personal experience, and that's also somewhere an unmet need, but being as fit as I am makes it even more challenging for doctors and physicians to really make a good diagnosis of the situation with me. Because it starts also with listening, not only at looking and or placing a patient in a certain corner. But I would leave it from now for this. So thank you, Emma.
Thank you very much for sharing, Mark. And your story is very poignant. And you've been through a lot with, two heart attacks before discovering that you had the elevated Lp(a). And of course, now you want to do the best for your children of elevated Lp(a) as well. And again, we're going to bring this into the discussion very shortly. But finally, I'd really like to introduce Assistant Professor Fotios Barkas, and he can share a little bit about himself and his expertise before we move on. Thank you.
Hi, Emma. Hi, everyone. So I'm Dr. Fotios. I prefer to call myself a doctor because the first thing that I am a doctor, actually a physician. I've been working as a physician in internal medicine in one of the largest lipid clinics in Greece, in Ioannina, for 10 years now. And I have to admit that I'm very lucky that I have been working so far with a group of other physicians that we routinely measured Lp(a) in our clinical practice. We had a lab in our hospital that can actually measure Lp(a), and we could identify those persons with elevated Lp(a). And indeed, unfortunately, these persons like Emma, like Mark, are at higher odds of developing cardiovascular disease. Unfortunately, though, like your stories, like the stories that you actually hear here today, most of my colleagues do not measure Lp(a) because either they're unaware of it or they can measure it. But it happens, and I have found out here in Greece, and it seems that the same happen in other countries in Europe. So we have to do something about it. And at the same time, yeah, I have been recently appointed as a professor in internal medicine in our medical school here in Ioannina. And another thing that I have to admit is the fact that when I was younger, when I was a medical student, I haven't been taught about Lp(a). I didn't know what it actually was. So the first thing that I teach my students now is what Lp(a) is and what are the residual cardiovascular risks that this condition is associated with, and what are the unmet needs of this person. So yeah, I'm very happy to be around you. And at the same time, I'm very honored to discuss about this condition and what we should do about it all together.
Great. Thank you very much for sharing, Fotios. It's really nice to get an understanding of where you are, and also from the side of a physician, that you make it a very big part of your, with your students, to make sure they understand about elevated Lp(a), because I think as a patient myself, I didn't say, but I also have elevated Lp(a). The three of us have had very similar experiences, one way or another, with underdiagnosis, misdiagnosis, being told that maybe it's something entirely different from what it actually is. And globally, it's estimated that 1 in 5 people have elevated Lp(a). Now that's it's 20% of the population. And just to use Fotios Greece as an example, I took the population for Greece on Tuesday, so this is as up-to-date information as you can get. So the population is currently 10.3 million in Greece. Now, with 1 in 5 people estimated to have elevated Lp(a), that puts the population of Greece as having 2 million people with elevated Lp(a). So then the question then comes into, well, why do so few people know about it? And how, as we as patients and healthcare professionals together, how can we advocate and educate and work together to ensure that more people are diagnosed and diagnosed sooner, so we have more people in Aidan's situation as opposed to Mark's or Imma's or my situation, being diagnosed as adults. And the other thing about elevated Lp(a), which I'm sure we all are aware of, there aren't any commercially approved elevated Lp(a) lowering therapies at the moment. So Fotios, would you be able to update us, please, with anything that's on the horizon with regard to the elevated Lp(a) lowering therapies, and what we can expect in the future, and maybe for future generations, how it can help?
Yeah, thank you. Yeah, I have to it. So yeah, you're actually right. Elevated Lp(a) is quite common. We do speak all these years. Let's speak about lipids. We do speak about FH. The prevalence of FH is 1 per 250 people. But as you have already said, elevated Lp(a) is much common. It's if we're 5 people here coming from the general population, one of us would have actually elevated Lp(a). So elevated Lp(a) is the most common inherited lipid disorder that has been associated with premature cardiovascular disease. And unfortunately, we don't know about its actual prevalence, and indeed is underdiagnosed. Not only the general population, but again, patients with established cardiovascular disease, like Mark, let's take for instance, would have 1 cardiovascular event or even more, and they would not have their Lp(a) measured at least once. And even in FH, because we do know that people with FH might have also Lp(a) elevated. We have data, because I've been part of the global FH registry, that globally, 1 in 3 individuals with heterozygous FH actually have Lp(a) elevated. So yeah, it's quite common, and at the same time, it is underdiagnosed. And Why does this happen in clinical practice? There are many reasons. First of all, like I have just said, most of the physicians do not know what Lp(a) is. Fortunately, I have to admit that during the last year, after the release of the consensus of the European Atherosclerosis Society, which advocates measuring Lp(a) at least once in every adult's lifetime, many people come to our lipid clinic because they have their Lp(a) measured, and but again, their physicians do suggest them to come to me because they don't know what to do about high Lp(a). And they might be true, I have to be honest, because we don't have any tool to fight it. We don't have any drug that lowers, or maybe we don't have any approved drug for Lp(a) reduction. Another thing would be the fact that at least many years ago, when we used to measure Lp(a) in our clinic, it was the fact that many hospitals could not measure Lp(a), or have to also underline the fact that there was no standardized method for Lp(a) measurement. For instance, someone comes with Lp(a) measured in milligram per deciliter, another one comes with Lp(a) in millimole per liter. So these have quite different values, and the patients or the physicians, they don't know what to do about them. They consider it at first high, but they're not actually high because they might be measured in nanomole per liter. So we need a common assay for measuring Lp(a) globally in order to have a better diagnosis of someone with a high Lp(a). And I don't know what happens in other countries about the reimbursement of Lp(a) measurement. So that would be another thing that we can work together and implement some health policies to reimburse the measurement of Lp(a), or maybe cascade screening, or measuring for Lp(a) in the general population. So yeah, we should measure Lp(a) in our clinical practice. We don't have, for the moment, any approved Lp(a) lowering therapies, but we do have 3 injectable therapies for the Lp(a) lower reduction, like pelacarsen, olpasiran, zerlasiran, that actually inhibit the Lp(a) production, and they can result in up to 98% Lp(a) reduction. So yeah, we have effective and safe upcoming Lp(a) lowering therapies, but we are waiting for the results of ongoing cardiovascular outcome trials to see if this Lp(a) reduction translates into a significant cardiovascular benefit. But again, I have to underline the fact that individuals with high Lp(a) can join these trials only if they are already diagnosed with established cardiovascular disease, because these persons are at much higher cardiovascular risk. So until then, the main question that arises is what we should do with someone with elevated Lp(a). Let's take Aidan, for instance. He's has already heart attack. So what he would question me, what I should do for the rest of my life. So until then, we just should intensify the management of other cardiovascular risk factors. We could maybe engage any dietitians or Aidan or the person that comes to me and adhere to a more dietary healthy pattern, increase his physical activity, stop smoking, of course, intensify maybe the LDL reduction in MARC or IMA. We should lower much his or her LDL cholesterol level with the available LDL cholesterol therapies. And of course, we should encourage our these persons that are attending us, are coming to our clinic, to join any upcoming or ongoing cardiovascular trials.
Great, thank you, Fotios. And yeah, I mean, without the lowering, the elevated LPA lowering therapies at the moment, preventative measures do clearly seem to be the way forward. And you seem to be quite ahead with this, and you've put a lot of thought into it. And Fotios, it's very clear to you that having a good diet, exercising, keeping the LDL levels as low as possible through existing medications such as statins, for example, is the best option that we have at the moment. Out of curiosity, for my own benefit, is there a specific type of diet that's better than another? Because some people talk about veganism, some people talk about Mediterranean diets. As a physician, do you have a diet that you think is particularly good, or is it just a case of eating, fruits, vegetables, white meat, fish, etc.? I'm just curious.
Yeah, there are data that advocates that maybe low carb diet might decrease LPA, but any effect, it is not so significant that could protect you or even result in significant LPA reduction, because we know that in order to have a significant clinical benefit, again, protect you from any cardiovascular event during your lifetime, we should achieve much higher LPA reductions, up to 90%. This isn't the same like LDL cholesterol. So we don't actually advocate for any specific diet. We do care only about diets that are cardiovascular protective, like Mediterranean diet, DASH diet, only these diets that have been proven that protect any cardiovascular risk in any individual.
Okay, so if we were to come in to see you with elevated LP(a), that would be the recommendation at the moment, would be, for example, the Mediterranean diet. Because
exactly. Yeah.
Okay, that's good. And I absolutely agree with you as well about having consistency in the measurements, because my understanding is not only is it different in between countries, it can also be different in between regions. And I'd just like to bring Mark in here at the moment, because Mark has been working on the LP(a) International Task Force, and I believe, Mark, that's one of the areas that you're focusing on. For those that don't know, the International LP(a) Task Force is a relatively new initiative, and it's set up by FH Foundation, and it's a collaboration. It's bringing patients together along with scientific experts and the pharmaceutical industry as well, to collaborate, to bridge the gap, to work out what we can do specifically for elevated LP(a). And Mark's been playing a big part of this. So Mark, I'd like to hand over to you, if that's okay.
Yeah, you already did a great job in in introducing in globally what the task force is. I can give a little bit more information, of course. So it's indeed a collaboration between scientists, patients, innovator, pharmaceuticals, industry, as you said, about education and bridging the gap between these groups. The joint mission of the task force is to ensure that elevated LP(a) is recognized as an independent and important risk factor for cardiovascular disease worldwide, of course. That's why it's called the Global International Task Force. Through what we call 4P medicine approach, and the 4 Ps then being prediction, prevention, personalization, and participation. When the task force is successful, every person on the planet is tested for LP(a) concentration at a most appropriate stage in the life course, which is embedded in combined screening and prevention programs, ideally before a cardiovascular event occurs. But of course, ideal case. So the aim of the LPA International Initiative is to ensure equitable access to LP(a) testing and management strategies, which should contribute to a global shift from cardiovascular disease and prevention towards a cardiovascular health, which is in line with the United Nations Sustainable Development Goal. So we've set a couple of goals in order to make it quite clear. And I noticed that the website of the Global Task Force was shared in the comments, and there you can read it all more. But the goals are to raise awareness about Lp(a), to demonstrate the cost effectiveness of cardiovascular disease prevention, to test personalized prevention models in health systems, to utilize effectively digital transformation and health data, and to devise a forward-looking research and policy agenda in Lp(a) anticipating trends. So it's quite a broad field which they focus on, but yeah, it should really create much more awareness and having said structural testing, which should be a big step forward.
Thank you, Mark. And I think that's the key thing, isn't it? With anything that we do, and I mean, the International Task Force is such a huge deal, because we're advocating for something that's incredibly common, and yet so few people know about it. And it's that knowledge, it's that understanding and prevention that we can, that comes into place, and it will hopefully help everyone, and people like Emma, like Mark, like Aidan, and like myself, from either finding out too late, or like Aidan's mum, not really sure where to get support from at the moment. And currently is a case, I feel, that we are supporting and educating our healthcare professionals as much as they are supporting us at the same time. Aidan, I'd just like to ask you a little bit more about how you find it. You've had the transition from being 6 years old with your diagnosis to being a teenager to going through to an adult. And I'm wondering, what's your perception and what sort of unmet needs have you had? And then I'll move on to Mark and Emma, because all of us with our different life stages and different stages of diagnosis are going to have very different perceptions on what unmet needs are, I think.
There are a lot of vast similarities, but also vastly different ways of approaching this, because I was diagnosed when I was 6, and that means I was a very small child. And a small child has a lot of trouble with understanding medical terms, and going to the doctor in its own right is scary enough for a kid, or at least that's the stereotype that everyone has with it. And that is why for a kid, the best thing to do is to approach them lightly and to elaborate them in some type of playful way what this disease entails, and try to just keep their attention by making it a bit of a game even, or at least that's what happened to me. And after a few times of me going to this doctor who explained to me what lipoprotein A would entail, I actually understood completely what it was. And as a small child, I could just be happy about it and not worry a single bit. And then I become a teenager, and all of a sudden you realize life is quite important. So you don't have that blissful innocence as a very small child anymore. And then after being told so many times what the disease entailed, it was very easy for me to just figure out what to do in life with it, and how to deal with it, how to make sure that I can live my own life without having to worry about a single thing. And as an adult now, I can say that nothing really has changed in that approach. I do think it is very important to note that when you are diagnosing a kid has a very vast imagination, and a very broad one at that. So for them to hear terms that are scary, and medical is scary for a kid, it is very important to avoid that, because if you do that, a kid will just lock themselves up in their brain with thinking, oh God, am I going to die tomorrow? Even though that is not the case. When it comes to an adult or a teenager closing in on being an adult, they would like to have some clarity. So it's important to be playful with a child, but don't be playful with an 18-year-old. Try to be a bit more direct to them, because they will understand then. But a child of 6 years old, don't do that.
Aidan, it sounds like you had a exceptionally good doctor on your side. Are you still with the same the same person?
Yes.
May
I
I
am
ask?
with that doctor.
Yeah.
As you may know him, maybe you've seen him in the webinar here. He goes by the name of Bert Wiegman, but he's my personal doctor. However, he's not the same doctor as my dad had, or my mother, for that matter. They went talking with their doctors that they had, and were like, "Do you have a colleague or someone that handles children? Because we want to test them." And it happened to be that Bert was capable of handling children. So me and my sister got diagnosed there. And fortunately, my sister doesn't have LPA or FH at all, but I do have LPA. My sister got lucky, but that don't matter. The main important thing is that what he did is he took me through it. He even drew a few pictures that to this day I can still draw. Because they were very easy to understand. They helped me understand as a 6-year-old what a disease in my blood meant without being scared of it, getting nightmares, or being like, oh Lord, something's happening to me that's not normal. And because of this, I've slowly been able to gather a bit of an understanding, getting to live with it. And now I just live my life happily, like nothing's different. But I can imagine that for children that don't have that treatment, or for people that aren't even diagnosed at all, they are left with quite some questions, and depending on their age, it's important to approach them differently.
Yeah.
Ada, may I ask a question?
Yeah,
Absolutely.
sure.
Yeah. Because you were so young, and you say, well, actually, not much has changed. But I'm very curious, as we just also discussed diets and something, and trying to get to a low LDL cholesterol level. Did you have to follow a diet, and were you not allowed to eat chocolate, and your friends were, or something like that? Or not at all.
No, thankfully not, because my LPA levels were manageable to just go around by. Basically, what happened is the following. My doctor, he stood beside me and he said, okay, there are a few things you need to do. Be active in sporting, eat a bit nutritious, so eat healthy, always eat your broccoli, that's stuff like that. And of course, don't smoke. That last part is very important. And the reason that's important is because he named it playfully with me in the beginning. But as I grew older, the more important I realized, if I start smoking now, I die by the age of 50. Like it won't work well for me. So that realization was very important for me. And because of this, and because of me being able to faithfully follow the advices that my doctor gave me, and that my parents are living with as well, because they also try to stay as healthy as possible. Yeah, the 5 golden rules of Albert Wiegman. It's important to just look into those first, because depending on your level and on the amount or more or less how heavy your LPA treatment really is, dietary changes could occur.
Yeah.
The 5 main things you need to be aware of is you need to always move, be sportive, you need to eat healthy, you need to watch out when you're crossing the road, that's for sure. You need to make sure that you're not smoking, and please don't drink. Those are the 5 main things. And if you're a 6-year-old and you hear, please watch out while crossing the street and don't drink alcohol. Like my doctor, he basically took me aside and told me, hey, do you smoke? And if you say this to a 6-year-old, they start laughing, because they're like, there's no way I smoked. There's no way. So you get into this conversation with a doctor that's basically not even just doctor-patient anymore. It's just almost two friends in that sense, because it feels like a very friendly conversation. And that allows for me, at least as a kid, to just completely understand what's going on, not be scared to go to the doctor next time as well. It's also a very big plus. So yeah.
Awesome. Aidan, thanks so much for sharing. And it sounds like you've had an absolutely wonderful experience with Professor Wiegman, and he's just supported you from being 6 all the way through. And it's nice to hear that you have that support. I'll move on to Emma, if that's okay, because of course you got diagnosed a lot later. So your unmet needs are going to be very different. And from my understanding, you went on a sort of an educational journey alongside your doctor, who also didn't really know that much about elevated Lp(a). So it would be great to hear a little bit more about that, if that's okay, please.
Yes, thank you, Emma. So you're right. I mean, I think that when I found out about Lp(a) and I discussed with my doctor, I think my doctor, as I said, who looked at it and from a very serious perspective, I don't think she was so much aware about it. So I think she started being interested through me, yeah, and supporting it via the discussions I would have with her. So I wonder at some moment also if there is a difference of or a generational gap, because I wonder if now younger doctors that are coming out of medical school have more information, because we begin to speak about Lp(a), but Eden would know this. I don't know if in universities they do speak. Maybe what I'm saying about the age, maybe 20 years ago or 30 years ago, they didn't even discuss this in university. So that also explains why, it can be something that is not so well known by doctors. So hopefully this is something that could change, and that that references or even more than references, a serious study can be introduced in the curricula for medical schools, no? And this is something that we should advocate for. So yes, thank you.
No, I do agree, and I'm sure Fotios, you agree too, and you are that sort of like the younger generation of doctors as well. Is it talked about more within?
Honestly speaking, I don't know. I don't have any frank idea about it, but what I do my best is to talk about it in my university. I know for sure, yeah, we teach about it, or we might give lectures, not also here in Greece, but internationally now, because yeah, you talk about Lp(a) and the need for screening everyone for Lp(a). But I don't know if this is included in every university teaching program. So I guess that I absolutely agree with Emma that we should teach about Lp(a), and every physician should know about Lp(a) and should measure when any person comes to his office and wants to treat him or prevent any cardiovascular event for him. Yeah.
Thank you. And with it being so common, with one in 5 potentially having it, do you feel that it would be really good to get the medical students to actually go and get tested as well? Because if you've got 100 medical students, 20 of them may have it. Yeah,
it's a great idea. Thank you for giving it to me right now. Yeah, because if I have if I do have 150 students, so yeah, we're expecting that 30 of them around might have elevated Lp(a), and all of them will definitely my screen their parents or definitely measure the Lp(a) of their patients in the future. Yeah, it would be a great idea for all of us that are dealing with cardiovascular disease prevention. Yeah, we could involve our medical students. Indeed.
Brilliant. I think that's a fantastic sort of step in the right direction, and it would be wonderful if there were more physicians as open and receptive as you, Fotios, to take this step and get their levels checked. We all have Lp(a). It just depends on whether it's normal levels or high levels. And as you've said, we only need one test in our lifetimes, because our levels stay the same from the age of 5. Apart from, I believe, women, when they reach sort of post-menopause, it may be necessary to have another test then, because our levels as females may increase.
You're right. They do have the trend to increase after menopause, but considering that Lp(a) levels are inherited and by 90% are genetically determined, in clinical practice, we do not expect someone not to have initially have low Lp(a), let's say 12 milligram per deciliter, that after her menopausal age will have much higher Lp(a). But yeah, Lp(a) tends to increase after menopause. But if someone, let's say, has Lp(a) around the cutoff of 50 milligram or 75 nano per liter. So yeah, we should again measure her LP after this age. Yeah, of course.
Okay. And Imma, is that something that you think about on your, on your future horizon? Because I know even at 44, I still think in the future that I'll want to get my levels tested again, just so I've got that additional knowledge and reassurance.
To be honest, I do not think my levels have changed from when I did the test 15 years ago to when I did it a year ago, for example, which I did. I think that the levels are, they may fluctuate a little bit, but it's minimal. At least this is what I have experienced. I do hear, and I keep on hearing that on menopause, cholesterol levels raise and maybe Lp(a) raises. I honestly don't know. I wonder if there is enough research done on this. The other thing that I wonder sometimes if there is research on the gender differences between women and men on how Lp(a) develops. And I mean, I have not seen, when I do a little bit of search, I have not seen information about that. But maybe it does exist, which I think could be interesting. To look at it as an unmet research, for example, no. So yes, I mean I'm not particularly worried myself, but as Fotios mentioned, normally the levels stay the same, but I have not experienced a difference in the levels, to be honest, between my phase of life now and 15 years ago when I was tested for the first time. So thanks, Emma.
That's good to know, and quite reassuring to hear in many ways as well. And briefly, just Mark as well. I'm very keen just to hear everyone's sort of unmet needs, and I'm very aware of the timing as well. When you found out that you had elevated Lp(a), do you feel that your needs were met by your physician? Because personally, I was 36 when I found out, and it was kind of a case of and I have FH as well, so it was a case of let's focus on the FH, because my doctor was more familiar with FH and how to manage that, as opposed to what to do with my elevated Lp(a). And so my situation is almost similar to Aidan's mum, that I've been kind of, don't worry about it, it's fine. So I'm curious to hear what your experience is as well.
For me, right? Yeah, sorry. So yeah, basically for me, I have, of course, the situation before I was diagnosed with elevated Lp(a), and afterwards, well, that went actually rather smoother. But in both situations, I think it's more the general questions: who, why, what, which pop in mind first. So when I first had a heart attack, or when I first was diagnosed a heart attack, which was actually later than the occurrence itself, it was, who, me? You have the wrong papers in front of you, right? This cannot be me. I walked a marathon last year. So that was really about confirmation that yes, it is you who just became a patient for life, basically. And then there's really the why or the how. How come that this situation occurred? What made it cause it to have become so severe, etc. And which was really difficult for me before the diagnosis, and went actually really smooth after the diagnosis, because that answered so many questions already to me. Because actually the not knowing part for me was most frustrating. So I can mention that. So when I was diagnosed with elevated Lp(a), it was quite clear quickly that I also had to test family members. So then also my two children, my two daughters, were diagnosed with elevated Lp(a). And that raised, of course, again questions, because that was not as smooth as Aidan mentioned on his relationship with his doctor, because I had, of course, the fear of having the heart attacks, having the operation, that I wanted them to not having to undergo the same. So I was really afraid. And my doctor was able to provide me with some answers. However, because there's still no drug on the market, etc., there's still some kind of fear and lack of information, which is really the unmet need. When should they be tested again? As what age should they have medicine to lower their cholesterols, or at what age are they? Are the risk factors really becoming an issue? These are the unmet needs were most important for us.
Yeah. Thank you, Mark. I'm just going to move on to some questions quickly, as an Albert we've had come through. Fotios, do you feel that we need to have a genetic test for elevated LP(a), as it is, as it is a genetic condition?
No, there's any need to do it. There are indeed certain polymorphisms that are associated with elevated LP(a), but there's no need to actually perform any genetic test. We should only just measure our LP(a) levels. It's just enough. There's no need to do any genetic test on this.
Do you have any hints or tips as well, Fotios, for encouraging people to get tested for elevated LP(a)? How can we as patients or just the community, how can we advocate to be tested, considering the number of people who may potentially have it?
With this, we all should underline the fact that it's just a simple lab exam, just like we measure our blood pressure, just the same thing as we measure our cholesterol. So we should measure our LP(a). Yeah, I agree that we can't do anything about it, but like Aidan said, and all of you, of course, it's very important to know that we have it, and we have to protect ourselves with every way we can in terms of healthy lifestyle, or even more aggressive cardiovascular disease prevention programs. Of course, you could also advocate for maybe joining trials, maybe doing national registries for LP(a), because at the same time, we, the academics and the physicians, of course, we need data, bringing together the data with you, all the patient groups, and going to a government, we could achieve something greater and implement health policies. For instance, let's say advocating for cascade screening or screening for LP(a). So this would be my advice for you.
Another option. Thank you. And we've just had another question directed at our patient ambassadors. The need for psychological support when we find out if we have elevated LP(a). I'm not aware personally of it being available at the moment, but is this something that we should invest in, from the hospitals, etc.? Is it a needed support, do you think?
That's a very difficult question to answer concretely, because it kind of depends on the person who's being diagnosed. Because and also on your age, also on what your situation is in, because your diagnosis of LPA can have drastically different effects from someone who doesn't smoke as to someone who does smoke, and that's just one factor. So the most important thing, yes, if you ask me in general, I would do so. And the reason I ask is because of two reasons. The first reason would be because you want to not only offer, the diagnosis itself and let them know what it is and everything. You also want them to be able to cope with it and deal with it. And that could be part of this psychological, I don't know how to put psychological support. But the second reason is also because being diagnosed is a scary thing in general. Every diagnosis that you are given, good or bad, it's information you need to process. And if it's something that has to do with your cardiovascular health, that is already something that scares many people. it is very important for them to realize that the effects that LPA can have, but also how you can deal with it. How can you manage it? How can you lower the effects or perhaps even nullify them? And a lot of research has also shown that the more stressed out you are, the less rational you become, and you want to avoid that as well.
Aidan, they're very good points, and I think the rest of us would agree with those.
Yeah, I think I would agree, because given the fact that Lp(a) or elevated Lp(a) is not a rare disease, however, it feels like a rare disease, but because there's so little knowledge about it, so that makes it more difficult, and that might bring a need for additional support, also psychological support. So we think we should work on it for two ways. So increase the awareness so that you don't think that you have a rare disease, and at the same time, if anyone needs help, then it should be provided, of course.
Yeah. And I think that's the key thing, and the whole purpose of this webinar, isn't it? It's to express what our perceptions are of unmet needs as patients, and then how we can come together with our healthcare professionals and collaborate, and if necessary, educate each other and work out the next steps and the best way forward. And the International Lp(a) Task Force goes a long way to do that. And then on a local level, it's us as patients advocating for the testing, really understanding what the preventative measures are, as well as, you know, the lipid lowering, the elevated LPA therapies coming forward in the future. Sorry, I do find that a bit of a mouthful. But it's what we can do in the here and now, and it's taking Albert Wiegmann's advice as well of don't smoke and look both ways when you cross the road, and exercise and eat healthily, etc. We're just coming up towards the end of the webinar. We have 3 minutes left, including me thanking the panel. We have one more webinar in the next series of unmet needs, and that is about FCS. Students, thank you so much for your time and giving up your evening. Panelists, thank you very much as well. I thoroughly appreciate it. With that, we will end the webinar. Thank you very much for this evening.
Bye. Thank you.
Thank you.
Bye.